From Redfield Medical Direction, I'm Lynn Nguyen, Associate Medical Director, and this is your August 2025 EMS Protocol Review. In the pre-hospital environment, we rarely get to change the outcome of the primary injury and trauma. What we can do, and what the evidence shows truly matters, is to prevent secondary injury. For head trauma in particular, that means avoiding hypoxia, avoiding hypotension, and maintaining appropriate ventilation. The data is pretty striking. In severe traumatic brain injury, just a single episode of a systolic blood pressure below 90 can double mortality. And when hypotension and hypoxia occur together, the combined effect is even worse than either one alone. We're going to start this review with head trauma because it's where those priorities are most clearly defined, the physiology is unforgiving, and small errors in the field can have outsized consequences. The Glasgow Coma Scale is one of your best tools for your initial assessment of head injuries in the field. The GCS was first introduced by a couple of neurologists in 1974 with the purpose of creating a simple, structured assessment to summarize a patient's neurologic exam. Since then, the GCS has become a universal tool, both in and out of the hospital, that helps us quickly categorize how severe a head injury might be, and it also gives us a baseline we can monitor for improvement or deterioration. In the setting of a head injury, a GCS score of 14 or 15 means mild TBI, 9 to 13 is considered a moderate TBI, and 8 or less is a severe TBI, where we start thinking about airway protection and definitive trauma alert activation. What's important to remember about GCS is that it is a dynamic tool, and what really matters is the trend over time. A drop of 2 or more points from a patient's initial GCS should raise concern for neurologic deterioration, especially in trauma. That could indicate bleeding, swelling, or impending herniation. In fact, one large study of over 250,000 head-injured patients found that about 9% of them got worse neurologically between the scene and the hospital based on GCS alone. And those patients had a much higher chance of dying in the hospital even after accounting for the type of injury or whether they had a brain bleed. This goes to show that the progression of a patient's GCS should help guide your decision-making. It tells you when a patient is about to get worse, and it gives the receiving facility critical information they can act on the moment you roll through the doors. Bottom line, know the GCS, use it often, and don't ignore changes, because the difference between a GCS of 13 and 9 could mean the difference between a watchful ED stay or an emergent trip to the OR. There are a few critical factors that can complicate our assessment and management of head injuries in the field. Let's start with intoxication. It's estimated that somewhere between 37 and 51% of adult patients who suffer a traumatic brain injury are intoxicated at the time of injury. That means in almost every other head injury you see, the patient may have alcohol or another substance on board, and that has a huge impact on how we assess them. An intoxicated patient can be agitated, confused, or may even be unresponsive or overly sedated. Those are also signs of a head bleed. This makes it hard to know what's really going on neurologically and why we should assume the worst until proven otherwise. If a patient has altered mental status and is intoxicated, don't brush it off as just drunk. We need to treat them as if they do have a brain injury because they just might. That means being cautious and over-triaging when in doubt. It's better to err on the side of safety and send these patients to a trauma center or higher level of care rather than leaving them alone. Blood thinners are also another huge red flag when it comes to head trauma. Patients may be on a range of medications that affect how their blood clots. Why do blood thinners like Eliquis, Xarelto, or Coumadin matter? These medications inhibit the body's natural ability to form blood clots, and so a seemingly minor head injury could be a high risk factor for intracranial hemorrhage. Multiple research papers have proven the concern for an occult or delayed head bleed, which typically happens within 24 hours of head trauma. Many researchers have looked into the risk of blood thinners in head injuries. A study published in 2006 showed patients on warfarin had a 6-fold increase in mortality risk. What about drugs like clopidogrel, more commonly referred to its brand name Plavix? You might hear some people say that these medications don't count as blood thinners, and those people would be technically correct. They're antiplatelet agents, which have a different mechanism of action from anticoagulants, but with the same end effect of inhibiting the body's natural clotting function. What have researchers found about patients with head injury on these medications? Based on the science, we still haven't reached a universal consensus about how significant a risk factor these medications are as compared to typical blood thinners. That being said, their effects can't be completely ignored. A large review of over 14,000 patients showed a risk of over 50% of intracranial bleeding after mild head injury. If you add aspirin to the mix, there's an even greater risk. All this is to say that if a patient with head trauma reports taking blood thinners, we should be thinking high risk. These patients need to go to a facility that can quickly do imaging and, if needed, reverse the anticoagulation or provide neurosurgical care. Let's talk about hyperventilation in head trauma, because what many of us were taught years ago isn't what the current evidence supports. For a long time, the standard teaching was that hyperventilating a patient with a head injury would help by lowering their intracranial pressure, which is true. Blowing off CO2 does cause blood vessels in the brain to constrict, which temporarily lowers the pressure inside the skull. But here's the problem. When we reduce blood flow to the brain, we also reduce oxygen delivery, and that can make a bad brain injury even worse. So today, the practice has changed. Routine hyperventilation is no longer recommended for patients with severe head trauma, especially not after intubation. We're no longer trying to blow off CO2 unless there's a very specific reason. For most head injured patients who are intubated, we should be aiming for an end tidal CO2 in the range of 35 to 40. That's what helps maintain good cerebral blood flow and oxygenation. But here's where we run into trouble. Accidental hyperventilation is still really common. Studies show it happens in up to 70% of cases. A lot of this is probably due to old habits and muscle memory from previous guidelines, or maybe because we don't always have accurate end tidal feedback while we're bagging. That's why continuous capnography is such a critical tool. Using end tidal monitoring in real time not only helps us keep CO2 in the right range, it also helps us avoid causing harm by hyperventilating patients without realizing it. Now, there is a place for hyperventilation, but it's very specific. If your patient is showing clear signs of brain herniation, things like a blown pupil, unequal pupils, extensor posturing, no motor response, or a sudden drop in GCS by 2 or more points, that's when you can temporarily lower the end tidal to a target of 25 as a bridge to definitive care. The important distinction to this exception is that it should be temporary and only for signs of herniation. If we hyperventilate for too long, we risk cutting off blood flow to an already injured brain, and that can lead to ischemia, which is essentially brain tissue starving from lack of oxygen. In summary, don't hyperventilate by default. Stick to an end tidal of 35 to 40 for most head injured patients. Use capnography on all intubated patients so you can monitor and adjust in real time. Only hyperventilate when there are signs of herniation, and even then, do it cautiously and temporarily. It's one of the most powerful ways we can protect the brain while we get the patient to definitive care. Taking someone's airway is already a major decision. Intubating a traumatic head injury is even more complicated. A major study from 2000 out of Los Angeles looked at kids who needed airway management in the field. It compared BVM ventilation to intubation and found no difference in survival or neurologic outcome, even in children with head injuries. The findings from the study are backed up by other research and current guidelines. In adults, most studies show worse outcomes when TBI patients are intubated in the field. But keep in mind, these are often the sickest patients to begin with, so that may be biased with the results. Still, two big risk factors stand out: failed intubation attempts and hyperventilation after intubation. A 2008 Cochrane review also concluded there's no strong evidence supporting intubation in urban EMS systems. The Brain Trauma Foundation recommends that if intubation is going to be done, it should happen under a structured protocol, with continuous monitoring of oxygen saturation, blood pressure, and end tidal. Training also matters. Systems with highly trained, experienced providers tend to have better outcomes. A large U.S. study of over 1,500 trauma patients with a GCS of 8 or less showed that intubation was linked to higher mortality overall, but also showed that agencies with more frequent intubation exposure actually had better adjusted outcomes. All of this tells us that the decision to intubate has to take in many different considerations, including transport time, available resources, and provider experience. It's not always a clear-cut answer, but intubation of a traumatic head injury should never be routine. When managing patients with head trauma, it's important to understand which treatments have proven benefit and which don't. Let's start with mannitol. While it's used in hospitals to reduce intracranial pressure, there's currently not enough evidence to support its use in the field. So at this time, it's not recommended for pre-hospital care. A multi-agency, double-blind, randomized, placebo-controlled trial done in 2010 looked at hypertonic saline given in the field for patients with severe TBI. They found no improvement in neurologic outcomes or survival, unless the patient was also in shock. Because of this, normal saline remains the go-to fluid for maintaining blood pressure in TBI. The Brain Trauma Foundation defines an adequate pressure as a systolic blood pressure of at least 90. What about albumin? This has actually been shown to worsen outcomes in head-injured patients, so it's not recommended. Steroids used to be popular, but studies now show they increase the risk of death, and so they're no longer used in TBI management. Lastly, let's touch on seizures. Seizures after head injury are dangerous because they spike the brain's metabolic demand and can cause more hypoxia. So you see one, treat it quickly. The risk of post-traumatic seizures is especially higher in younger children. But, and this is key, there's no evidence to support giving seizure medications prophylactically in the field. In other words, if the patient isn't actively seizing, we don't give meds to prevent one. Our approach to spinal care in trauma has evolved over the years, particularly within the last decade. We know that unstable spinal injuries can become much worse with unnecessary movement, potentially leading to serious, lifelong neurological deficits. That's why spinal motion restriction has historically been a fundamental part of pre-hospital trauma care. The key word is restriction. The goal is to limit movement, not eliminate it. What does this mean exactly? We should apply spinal motion restriction for trauma patients who have signs suggesting a potential spinal injury. That includes patients with an altered GCS. It also includes anyone with midline neck or back pain, focal neurologic signs like numbness or weakness, visible spinal deformities, or distracting injuries that prevent a reliable exam. Once you've decided spinal motion restriction is needed, it should include a properly sized cervical collar and a method of maintaining the head, neck, and torso in alignment. What matters is that the spine is supported and movement is minimized. Remember that this cannot be done in a sitting position. One of the highest risk moments for spinal movement is during transfers, like from the ground to the stretcher. So take extra care during these transitions and use tools like longboards or scoop stretchers to move the patient as a unit to minimize any bending or twisting of the spine. Now, once the patient is safely on the stretcher, you don't necessarily have to leave them on the backboard. If you have enough trained personnel that can do so safely, the backboard can be removed in the field. But this decision should be balanced with the risk of manipulating the patient against the benefit of removing the device. In other words, for short transports, it might make more sense to leave the device in place and remove it at the hospital. Hospitals, for their part, should be prepared to get patients off backboards quickly. One very important point, there's no role for spinal motion restriction in penetrating trauma. In cases like gunshot or stab wounds, spinal motion restriction has been shown to cause delays and increase the risk of death without any proven benefit. Management of pediatric spinal motion restriction is similar. Just like with adults, it depends on symptoms and mechanism. If the child has neck pain, torticollis, neurologic deficits, altered mental status, or high-risk mechanism like a diving injury or a major MVC, then a collar is appropriate. In younger children, be aware of the larger head-to-body ratio. You may need to add padding under the shoulders to keep the cervical spine in a neutral position and avoid unintentional flexion. And finally, just like with adults, we want to minimize the amount of time kids spend on the backboard. Use extra padding to help reduce pressure-related injuries if prolonged spinal motion restriction is unavoidable. Overall, spinal motion restriction is important, but it needs to be used selectively and thoughtfully. Our job is to protect the spine from further injury, but we also need to avoid causing new problems with the techniques we use to help. We can do both by using sound clinical judgment and staying current with evidence-based guidelines. Lastly, let's review our management of traumatic hypotension. In the traumatic patient, hypotension is most often than not caused by massive hemorrhage. But there are cases where patients might be suffering from neurogenic shock caused by a spinal cord injury or severe TBI. Alternatively, the hypotension could be obstructive from something like a pneumothorax or cardiac tamponade. In reality, it's probably a combination of all these things happening at once. No matter the cause, our primary goal is to maintain enough perfusion to make sure the major organs are alive. That's why hemorrhage control, volume resuscitation, and needle decompression are the mainstay interventions in managing trauma-related shock in the field. But what about pressors? Should we be using them pre-hospital for hypotensive trauma patients? The National Association of EMS Physicians actually released a position statement at the end of last year that takes a deep dive into this question. And the bottom line is pretty straightforward. Vasopressors do not have a routine role in pre-hospital trauma care. Let's break the position statement down by scenario. In hemorrhagic shock, vasopressors are definitely not recommended. In fact, studies suggest that giving vasopressors in this setting might actually increase mortality. Raising the blood pressure without stopping the bleed can just push more blood out, worsening the hemorrhage. In these cases, bleeding control, TXA, and volume resuscitation with permissive hypotension is needed. What about spinal cord injuries or neurogenic shock? In the hospital, vasopressors are often used to maintain a MAP of 85 to 90 to keep the spinal cord perfused. But for us in EMS, there's no strong evidence that vasopressors help these patients in the pre-hospital setting. That doesn't mean that they're harmful, it just means that we don't have enough data to support or oppose their use. Our protocols dictate starting a levo drip as soon as you start fluids. There might be more definitive recommendations in the future, but EMS as a whole is just not there yet. Finally, let's bring it full circle, back to the traumatic brain injury. We started off this review with the fact that a single low blood pressure reading is associated with much worse patient outcomes. So yes, blood pressure management is critical, but the data just isn't there to show any benefit of pressors for blood pressure management of TBI. That means we should continue doing what we know works. Prevent hypotension, prioritize oxygenation, and use fluids as our first line tool. A lot of research and study still needs to be done for us to advance our care of trauma patients in the field. Until then, stick to the fundamentals. Control the bleeding, use fluids judiciously, avoid hypotension in TBI, and transport quickly to the right facility. That's where you can make the biggest difference. And that's all we have for this episode. This was a production of Redfield Medical Direction and produced by me, Lin Win. Our theme music is by Infraction. As always, reach out if you have any questions. See you next time.